Hello, good morning. We're still morning. I do want to thank the organizers for inviting me to be part of this wonderful educational symposium. I have been asked to address the issue of what progress we've made in the systemic therapy of colorectal cancer. So, how do we define progress in the systemic therapy of colorectal cancer? Well, first of all, what seems most obvious is we can find new effective drugs. We can define new adjuvant therapies, and the definition of adjuvant therapy is something that is done after the surgeon has removed the cancer, and it is designed to enhance cure by reducing the likelihood that cancer will ever come back. We can find new therapies for disseminated disease. This is for people who have cancers that have spread beyond the colon and are not amenable to being cured surgically. But what we want to do in this setting is prolong life with controlling disease symptoms. But most importantly, I think, is that we can begin to develop an understanding of what drives the cancers. So there are basically three historical eras of systemic cancer therapy and colorectal cancer treatment. Between 1960 and 1990, we had one drug, and we tried using it a whole lot of different ways. Between the mid-1990s to the mid-2000s, we acquired a couple of other effective drugs, and so now we had more things to manipulate. And the targeted area of therapy, and you read a lot in the newspapers and magazines about targeted therapies, started about the beginning of 2000 to the present. But now what I think is most exciting is that we are entering the age of molecular selection, and I'll be talking some about that. So this is basically the palette of drugs that we have to use in systemic therapy of colorectal cancer. We have the old drug 5-FU and the newer form of 5-FU as a pill. We have irinotecan, we have oxaliplatin, and we have a whole variety of combinations of these drugs. In the newer arena, we have targeted agents such as cetuximab and panitumumab and bevacizumab. These are all great names. They all refer to antibodies. And there are two new drugs that have just been approved in the last year, regorafenib and something called aflibercept. So let's start by defining what is the current adjuvant standard therapy for colon cancer. This is above the level of the rectum. So for stage 2 disease, when no lymph nodes are involved, you can either treat it as stage 3, and there is a camp in this country that prefers to treat it this way, or patients can be offered participation in clinical trial. It is of note that there are beginning to be tests on a gene level which will define which stage 2 cancers behave more like stage 3 and therefore might benefit from treatment. For stage 3 colon cancers, when it has spread to the lymph nodes, we recommend 6 months of therapy with either FOLFOX or FOLFIRI. These are just acronyms for using all of the drugs that we have available, or capecitabine, or involvement in a clinical trial, because that's where we get to both use new drugs and find new therapies. Now, for rectal cancer, as Dr. Bernstein mentioned, it's a little bit different. The standard therapy at present involves giving treatment before surgery with the drug 5-FU along with radiation. And then following surgery, there's a recommendation for some additional chemotherapy depending on the stage of disease. Older therapy included having the surgery first and then receiving the chemotherapy and radiation after the surgery. However, this has become less in favor, and in point of fact, the trend is to move all of the therapy, all of the chemotherapy and radiation to a time before the surgery is accomplished. And again, as you note, I keep referring to possibility of enrolling in a clinical trial, because from our perspective, everything that we have learned has been on the basis of clinical trials, and so going forward, clinical trials are very important. For stage 4 disease, when the disease is already spread beyond what the surgeon can cure, usually first line we use FOLFOX plus one of the antibodies, bevacizumab. Second line could be irinotecan plus one of the other antibodies, or varying combinations of those in the third line of therapy, or again, enrollment in a clinical trial. But do we know how much therapy we actually need? And in fact, is less better? So that is the focus of the current trials that are going on in this country on a national basis. This is the trial for stage 3 colon cancer. And basically what this is doing is asking, can we do as well with 6 treatments, which is about 3 months of therapy, versus 12 treatments? And then further, after all of the chemotherapy is done, there is a randomization to a drug called celecoxib, which some of you may know is an anti-inflammatory drug that's used in arthritis, because one of the pathways in colon cancer is based on the target of this drug. For rectal cancer, now this looks like a whole lot more complicated, but basically it's asking a very simple question. If we give chemotherapy first and the cancer responds very well, can we eliminate the radiation therapy and go straight to surgery? Again, is less possibly better? So now I want to move on to what periodically pops up on the covers of various magazines, targeted therapy. And we've all heard the term personalized medicine. So targeted therapies are a step in the development toward personalized medicine. All cancer treatments on a systemic basis have targets. However, some of the targets are expressed more broadly than others. So the more target there is in normal tissues and normal organs, the more toxicity or side effects are going to be seen with that treatment. Some targets may not be the ones that actually work in a given cancer, so we might be giving a targeted therapy where it doesn't work. What we really need is a smart bomb and not an atomic blast. So I want to take a minute to show you a number of the things that can go wrong in a normal cell to make it a cancer cell. Cells are always surveilling their environments through receptors on the surface, and when they see too much of growth factors in the environment, they may rev up and start to divide. This can get uncontrolled and they can become a cancer. Likewise, with inside the cell, we can get revving up of the pathways that direct the cell to divide. We can also see cancer cells excrete agents that allow them to attach themselves to our blood supply. Cancers can invade their local environment, and they can actually secrete things that turn around and make them grow better. So there are a lot of things that can go wrong in a cell to make it a cancer, and all of these are potential targets for therapy. So for instance, one of the first agents that was developed in colon cancer as a targeted therapy is what we refer to as an anti-angiogenic agent. So what this is a picture, a cartoon, if you will, of a normal blood vessel. It's straight, it's organized, everything occurs in a normal interval. But cancer blood vessels are irregular, they're leaky, they don't have all of the outer lining, and when you look at it as a pathologist might, they could look like a spider web. So they're very different from normal blood vessels. So one of the things that allows cancer blood vessels to develop is something called the vascular endothelial growth factor, or VEGF. And one of our very first targeted agents in colon cancer is a drug called bevacizumab, which is an antibody that blocks this VEGF from going to its receptor on the cell. One of the newer drugs is trapping the VEGF in the circulation. So there are a lot of different approaches to prevent the cancer cell from attaching itself to your blood supply. So this is a monoclonal antibody, reduces the cancer's ability to make its own blood vessels, and it has been combined with chemotherapy in a number of cancers to shrink cancers and stop progression. By itself, it hasn't been shown to be as much of an active agent, but it does work well in combination with chemotherapy. So when this data was presented in 2003, this was very exciting because this was in patients who had cancers that were not curable, and this is the patients who were treated with the traditional chemotherapy on the white line, and on the purple line, this was the group of patients who received the Avastin in addition to the chemotherapy regimen, which was IFL. So it's very exciting when you see the curves separate, because that means we're doing better with our new treatments. A second study added the bevacizumab to one of the other chemotherapy regimens, FOLFOX, and basically saw the same thing. This is the chemotherapy plus the FOLFOX, and this is chemotherapy or the antibody by themselves. So what we would really like to do is something a little different from what has been done before. And this is to be able to identify those patients who are going to get benefit from a therapy. Because in the bevacizumab or Avastin studies, everybody got that treatment. So what we would like to do is have a test that would take everybody with a disease and to find those who have a positive test and therefore are going to get benefit, and those who have a negative test and therefore are not going to get benefit from a specific treatment, and therefore we're not going to give it and risk its side effects. So we do have some data in colon cancer for that, and this is with the epidermal growth factor. It's overexpressed in colorectal cancer. It mediates one of the signaling pathways in the cell, and it does have monoclonal antibodies that have been developed to block it. Unlike the bevacizumab, this does have some response in cancer by itself. So this is a cartoon of how this works. So we have the receptors here and the epidermal growth factor here. And when they're activated, they bring on this whole cascade that goes down into the nucleus of the cell and says divide. And if it does this enough time, then we've got uncontrolled growth of a cancer. These are the antibodies that we currently have available for treatment of colorectal cancer. One is cetuximab. Chimeric just means it's part mouse. The other is panitumumab, which is a fully humanized antibody. And this is, again, showing where they work. Antibodies work on the outside of the cell and prevent the receptors from activating. We have newer agents also, usually in pill form, that are called TKIs, that work on the inside of this signal. So how do we integrate how cancers develop with their treatment? KRAS is a gene that is prognostic for response in colorectal cancer, and it's a very early event in the development of colorectal cancer. It turns on that intracellular signaling cascade, and it generally has been associated with poor prognosis in terms of outcome. But more importantly, this is back to the population. This confers resistance to the antibody, to the epidermal growth factor, so we have defined a population that we can give the treatments to and a population that should not receive the treatments. Fortunately, the population that we can give the treatments to is about 60% of patients with colorectal cancer. So there was a study of about 600 patients in each arm adding this to chemotherapy, this antibody, and this is the outcome. So if we took the whole trial, there was a benefit to adding cetuximab to the chemotherapy regimen, much like we saw with the anti-angiogenesis antibody. In terms of overall survival, not so much difference. But when we went back and looked at who in that population had this gene that was functional and wild type, they did much better than the general population, and it was more significant. And even though not statistically significant, it was better in the outcomes. So we are beginning to be able to use a test to define a population who are going to get benefit from treatment. This was also tested for the other antibody, and in this trial it was against what is called best supportive care. And again, the antibody worked when the KRAS gene was wild type, not mutated, and it tells us who we should be giving this treatment to. So what do we accomplish with all this? Well, back with no treatment at all, metastatic colorectal cancer has a pretty short prognosis, and people on median survive about 6 months. With one agent, that was extended to 12 to 14. When we added 2 agents, out to 15. When we were able to use all 3 of the active chemotherapy agents, we're out to about 24. When we add the cytotoxics, we're out to 20, and I would say I couldn't get the newer slide of this, but we're actually out to about 2.5 years now, and expect by 2018 to be at about 3 years of survival in incurable disease with our new agents and with better selection. So just to revisit, this is our cartoon pathway of what happens in a cell. So we've got a receptor, and it sets off things here, and these are some of the places that we begin to develop drugs against various genes. And that all seems like it's pretty simple, and we should be able to do that and move ahead fairly quickly. But that's just the tip of the iceberg. This, in reality, is what it looks like more. There are multiple pathways, lots of redundancy, lots of crosstalk. It's complicated. So, what we have now are technology that will allow us to take pieces from the cancer and analyze it for genes that are either more expressed or less expressed, and then go look at another set of patients and find out which one of those are relevant. And we can now do this with machines that will fit on a countertop, and we can analyze thousands of genes at a time. The problem is figuring out what to do with all of that information that we generate, because not all of those genes are going to be relevant. So in the future, phase 1, 2, and 3 trials must include molecular parameters if we're going to make progress. We can start by selecting the pathway that cancers develop, and there are different pathways. We can start to look at the genes that we know about, like KRAS, and then stratify for different genes, and then each piece of information is incorporated into the next generation trial. And if we select populations by molecular expression, we will find smaller trials conducted over a shorter time for a greater benefit for the patients enrolled and the population. So in the approaching age of personalized medicine, and this is our goal, the cancer will inform us of its appropriate therapy. It's in the genes. And I thank you for your attention.